Good morning, everybody. If we can all make our way to our seats so we can get started this morning. My name is Lori Moore, and I'm the clinical educator at GOJO Industries. And on behalf of all of the GOJO team, we want to welcome you to our Symposium breakfast. So on to why we're all here this morning. So hand hygiene is always top of mind for everybody. We're still dealing with the old long-standing challenges, but now over the last few years, we have new challenges that everyone's dealing with. I do a lot of the CE presentations online, and I'm sure that I've seen many of you here through my presentations, but there's always this kind of downheartedness about hand hygiene and what's happening and solving all the problems. So to that end, our speaker this morning is the hospital epidemiologist and executive medical director of the Infection Prevention and Control Program at the University of Chicago Medicine. But her superpower is hand hygiene and behavior change. It is her superpower. And you know, we all think about hand hygiene in terms of risk management and patient safety and decreasing HAIs. But the reason it's her superpower is that she believes in hand hygiene to the core of her very being. And she also believes that any time that we walk away when we see someone not performing hand hygiene, we are violating ethical principles. So for her, it's more than just risk management and infection prevention. It's about professional imperatives and really doing the right thing. So this morning, I want you to give Dr. Emily Landon a warm welcome as we bring her to the podium. And this smile that you see on her is what she has all the time. Through her problems, through her challenges, her staff will say she keeps us positive about hand hygiene. So this is going to be a great presentation. And Dr. Landon, thank you very much.
Thank you so much, Lori.
Yep.
Oh my gosh. Listen, I'm this positive unless you don't wash your hands. And then all of a sudden it's a different look. Listen, so I love giving this talk at I've done this symposium thing before for GOJO and for other people at APIC, and I tell people, oh, I'm going to go give this talk at 6:30 in the morning. And they're like, who's going to go to that? And I was like, infection preventionists. And they're like, got it. I'm like, it's packed. You guys are the best. So let's talk today. I'm not going to sugarcoat. I don't sugarcoat. Like that, there's no point to that. Hand hygiene's hard. We're going to talk about that. But first thing I want to make sure we cover today, I have no disclosures other than GOJO paying for me to be here today. They paid for my travel and my accommodations. But otherwise, I have no other disclosures. I mean, I wish I did, because then I'd have more money. But I do not. So this is just a slide that tells you that hand hygiene is hard. We're going to skip it. You all know that part. But what are we really going to talk about today? We're going to talk about where we are now, because things are a little different after the pandemic. I mean, we all did that together, right? We stopped doing our day-to-day jobs, and we did this emergency for a while. And then things got really politically difficult for all of us. No matter which side of the spectrum you're on, it made infection control sort of not so fun anymore for people. And it made it harder for us to do our jobs. And then we have these new leapfrog standards that are like really hard, and they're kind of my fault. And I'll take responsibility for that, and I'm gonna help you understand why they're so hard and talk about how we can get there and why it's important and what the philosophy is behind that. And then the thing that bothers me the most and that has been affecting me every single day for the past few years, and I think many of you are in the same boat because a lot of my friends that do this job that I do in other places have the same problem, is like, oh, well, we just can't afford that right now. We just can't afford it. And so I feel literally like I'm being told, oh, patient safety, we just can't afford that anymore. And it's heartbreaking. And so how are we going to work with that? What are we going to do with that? And how are we going to move forward from there? So that's what's on the agenda. Okay, enough of that. Let's go back to the pandemic. This is a paper that we wrote in the like sort of in 2021 about the hand hygiene. You know, we use the GOJO SmartLink system at my hospital. It's an aggregate hand hygiene monitoring system. It's not badge-based. It just basically counts how often people go in and out of rooms and how often people use hand sanitizer or soap, right? And so we get a numerator and denominator. And you can see the blue line here is the hand hygiene opportunities, and then the hand hygiene compliance is here in the black. And this is the COVID cohort units. It's really just whatever they before COVID, and then what they became cohort units during COVID, but the staff was the same, because if you worked on a unit that became cohort, whatever. Bottom line is that they ended up having, I did nothing for hand hygiene. I mean, I didn't have time. I was busy trying to like make the rules for how to take care of COVID patients. And you can see here that during the COVID pandemic, the hand hygiene went up to nearly 100% without any effort, but also those hand hygiene opportunities. People didn't go in and out of the room so much. Now, they still took care of the patients. They just batched their tasks and figured out what to do in order to get the work done and also protect themselves and the other patients. So we know that people know how to do it. We know that they can figure it out. We know that when they're motivated and focused on providing care in a safe way and doing it in a way that's going to help them preserve their own safety, that they're going to do it. And then as soon as they start to see, as you can see in like June and July, as soon as they start to realize that this doesn't pose so much of a threat to them, and that maybe they're not transmitting COVID from patient to patient, or all the patients on the unit already have COVID, that what ends up happening is that the hand hygiene went right back down to where it was before. And so we can clearly see that people don't value hand hygiene the same way that we do. And that's going to be important as we move forward. I just want to start off by pointing out that hand hygiene is a really tricky beast. And it's tricky because of exactly what the pandemic showed us. When there's a focus time and everybody's really looking at it, they can do it just fine. And then when things start to focus and shift on to other priorities, it's one of the very first things that gets cut, the quarters that gets cut. And you can see, these are some graphs from three of our different units. And the one that's up on the top there is our burn unit. They run pretty great compliance almost all the time. You can see that those bars that show, like the lines are not in the same place because different units have different goals in our hospital. So you can see that they run really well in the winter time when they have mostly burn patients on their unit and frostbite sort of patients. They do really well. And then when they have more trauma patients coming in during the winter, or during the summer months, they get sort of like boarders, and those patients just don't wash their hands as much for them, which means that those staff understand and they value the hand hygiene more when they're taking care of a patient that they can see a lot of open wounds and like a lack of skin integrity. But why do they feel like the patients with the trauma don't need it? These are the things that keep me up at night. Like, why is it that we can do it sometimes and we can't do it others? Down here underneath the hand hygiene is a tricky beast. You can see this is one of our units that isn't very good. They were the trickiest, and we're going to talk about them in a minute. They were the trickiest ICU. They just never really got above 50%. Most of my ICUs run in the 70% range all the time, and then they had an outbreak of Candida auris. And you can see right there where they go bump right on up to 85%, and they've been sort of sustaining above 60 now, but they're still not doing as well as they were when they were in the middle of that outbreak. And then over on the other side, we've got a unit that's just a regular old observation unit where they're just running it like less than 40% or around 40% all the time. You know, oh wait, that's one that's at 59. But they're not great, right? I've got units that run 35 all the time, and I've got units that run 85 all the time, 95%. And it's unbelievable, and I can't really figure out what's the difference between the two, and that's what we need to figure out in order to understand how to get from where we are with hand hygiene to where we're going with hand hygiene. And the reality is that there's not a lot of easy ways to do the research to answer that question, because there's no one-size-fits-all solution. I can tell you, whatever you do in one unit, if you try and just import that, or export it, I guess, to another unit, it may not work at all. It may be totally useless. One unit that wants to use their unit secretary to page out every time the hand hygiene goes lower than 40%. You ask another unit to do it, it doesn't work at all. And that makes it really, really hard to approach hand hygiene. So I want to impose upon you the idea that culture and social pressure play a huge role, and that the more you can get people to do hand hygiene on a unit, the more people are going to do hand hygiene on that unit. And once you get into that positive spiral, you're going to start to see improvements, and you can learn from that to make suggestions to other areas. But the reality is that this isn't about patient safety or risk management or leapfrog standards that we're reporting to the national reporting things. This is about behavior change. And it's really hard to change behavior. I mean, we would never reduce smoking cessation to just don't buy cigarettes anymore and you'll be good, right? Who's ever talked to somebody who smokes? That's not how it works. And how about weight loss? Oh, we'll just eat salads now. Oh, that's not how it works. You have to do so much more. There has to be this internal locus of control. You have to decide that you want to do it. You have to make a commitment to do it. You have to change your behavior. You have to find ways to avoid your old behavior. There's like a multi-step process inside each and every nurse, every EVS worker, every surgeon has to have this personal epiphany that they need to change their behavior about this. And I don't know about you, but like, I can be really, really positive and I can be a great cheerleader, but that's a lot to expect of a bunch, like, I don't know, we have like, what, 6 infection preventionists for 700 beds because, we're super understaffed. Yeah, that's what they're gonna do. Personal epiphany for everybody. So we don't have a lot of experience with that. You guys have more than your frontline leaders probably do. That nurse manager who just got appointed as nurse manager, they were a night shift nurse or an ICU nurse before that, and now they're a manager. They don't have a lot of experience about changing a whole bunch of people's behavior, and you don't have that either. But frontline leaders do know their teams, and they know their environments better than anyone else. But nonetheless, if you want people to change, they have to go through the same stages of grief that were described by Elizabeth Kubler-Ross when someone is dying, that they need to go through. These denials, the anger, the bargaining, the depression, and the acceptance, and you bounce back and forth between them. It's not just a one-directional arrow. And we see it every single time we talk to a unit manager. I have to get that unit manager through all of those stages to a place where they accept that they can actually change hand hygiene if they put some time and effort into it. And then they have to get each and every person on their unit through that. So don't give yourself a hard time. It is really, really hard. You can't just say, well, just wash your hands. That's so easy, right? It is never that easy. And so you have to make progress just a little bit at a time, and you have to celebrate every win that you have. You're also in competition with a lot of really important stuff, right? You've got the EMR, which is asking people to click on literally everything in order to make sure that everything has been documented at any time. I mean, don't you wish you could just hard stop hand hygiene in the electronic medical record? Like, that's the solution for everything now, right? If you could do that, you'd be fine. Except that's kind of wrong. People ask me that. They're like, why don't you just lock the doors until people wash their hands? I'm like, because we're not a prison. It's a hospital. And they're like, oh, yeah. So, you have to allow for people have to actually want to do this. And there's all these alarms, there's all these monitors, there's sick people, and every single person in the clinical setting is trying to do a job that's hard for them, that is at the top. I mean, not everybody's working at the top of their license all the time, right? Because we're being asked to do a lot of silly administrative tasks frequently. But the reality is that there are a lot of tasks that are at the top of our license, that are at the top of our ability. And people are being asked to do that all the time. And you're saying, can you also just wash your hands? And they're like, yeah, sure. Because they're really focused on those things that are hard for them to do. And we have to understand that, and we have to figure out what we're gonna do. So Leapfrog put together this whole group. There's some of us here, some of my colleagues on this group, where we made these standards for hand hygiene that everyone hates. I get it. I don't blame you. But this is how Leapfrog does their stuff. I didn't understand this, until I was part of one of these technical advisory teams. And I learned that they're trying to push hospitals to make the right choices in terms of their investments through their requirements. And that's the point of these requirements. And so these domains that we have for the Leapfrog hand hygiene standards are complicated, right? The monitoring standard is the one everybody hates the most because you have to have like 200 opportunities per month or 100, but then you have to meet all the other domains. There's a reason for that, and I'm gonna show it to you in a minute. But it's not when your hospital says, fine, you'll have to stop doing something else in order to do those observations. That is them making a bad choice. It's not leapfrog making a bad choice, okay? But the feedback part, giving people the feedback, I think the other ones are pretty easy. You gotta educate people, you gotta check on them, you've gotta make sure they actually know how to wash their hands properly. You've gotta make sure that the people who are doing the observations are educated on how to observe for hand hygiene. You gotta go back and check in with people. You've gotta do stuff to improve your culture. You've gotta your leadership needs to be involved. These are all welcome things that I wanna see in my hospital more of, and that you wanna see too, and we can be grateful for those. But let's talk about why so many observations. So I've got an automated monitoring system, so I know how many observations make a difference, right? But I'm gonna remind you about this. This is something that I think one of my science teachers showed me in like high school, that if everybody's looking at a microscope at a different part of an elephant, they're gonna come up with a completely different idea of what that elephant is. And this is what happens when we only do a few observations in a unit. We only observe between 9 and 5 p.m. on Monday through Friday. We're only seeing the tail. We're only seeing the tusk. We're not really seeing the whole picture of what hand hygiene looks like. Now, does 200 observations actually give you the whole picture? I don't know. Does my 100,000 observations give me a whole picture? Maybe a little bit better picture, but still not everything I need. So this is actually a recently published paper that is called Right-Sizing Observations, and the point of the paper is to say that leapfrog is wrong and that we shouldn't need to do all these observations. They took 200 observations from a unit, and then they did they randomly extracted a few, like 50 or 100 or 125 or whatever we're looking at here on the chart, observations from the 200 observations, and they saw how different that sample is from what they got, the compliance they got for the 200. And that bottom line there, the purple line, that is the 90% compliance. So if you had 200 observations showing 90% compliance, then yeah, 50 observations is going to show you the same thing. But that top line there, that's the under 75% compliance. And you can see that if you only do 50 observations as opposed to 200 observations, then you're off by maybe a quarter, 25%. And I just showed you a bunch of pictures from my automated monitoring hand hygiene thing way back. Remember, I walked you through those different things, where my best performing units are maybe at 80%. So when I've got most of my units, when we started, we're at 30 to 35. How big of they didn't even show me the graph. The graph would go off this slide for the difference between 50 observations and 200 observations. And most of your units, if you're not using an automated system and you're not like super amazing, because most of mine still run about 40%, even though I've been doing automated monitoring and hand hygiene evangelism for like 10, 20 years, right? I mean, the bottom line is that this is really hard. And so the more you can get in terms of observations, the more you're going to be able to see what's actually happening. So this is how many observations our system picks up. Now, I'm not saying you need this. I am telling you what the magnitude of actually how often people go in and out of rooms, because I can tell that, because I know, because I monitor how many times a warm body walks in and out of a room. That's just part of the system, right? So how many times does somebody walk in and out of a room of a patient on mother baby? 77. That's entries and exits, so probably only half of that, right, to be fair. 77 in one 24-hour period. Look at that hospitalist medicine. 181 hand hygiene opportunities related just to walking in and out of the room. That's not even counting like when somebody empties a Foley or puts in an IV or does any of that other stuff. That's just walking in and out of the room 181 times a day. 200 times a month is not that much, right? Now, obviously, there's a feasibility issue. I am not saying that we need to stop doing everything else in infection control and only do observations. But we do have to think about what the limitations are of what we have. And so you're definitely not seeing the whole picture. At my hospital, we monitor 137,484 hand hygiene opportunities per day. At least last week, that was the average. I took the numbers. And that's for a 700-bed hospital that includes a children's hospital. That's not a lot of beds. That is a lot of hand hygiene every day. And that doesn't include outpatient, it doesn't include the ERs, and it doesn't include the NICU, because bed spaces are hard to monitor. That's a lot. So where are our blind spots? I have blind spots. Our system is imperfect, right? Every system, no matter what you have, is going to have blind spots. we count some of our rooms are so tiny and so old that like anytime somebody peeks their head in, it's going to count them as having entered the room. And so maybe that number's a little bit too high. But also, we know that sometimes people are, 3 or 4 people are going into the room, and it's only counting them as 1 because they're going in together. I've got big rounding teams because it's an academic medical center, and that happens, and we know it. We also know that sometimes EVS has like literally their hands are full of disinfectant, and they're walking in the room. They don't need to wash their hands at that time, right? So we know that there's blind spots everywhere, and we know that there are blind spots with your observations. The question is, what are they? And how can you figure out how to make it work a little bit better? So let's talk about it. 5 ways to get more observations or better observations. And there are some good references here that are recent and good. So the first one is think about crowdsourcing. It is really important to have good observations done by a trained observer, but it's also really good to have everybody in your hospital thinking about hand hygiene and able to access and write down those observations. Emily Sickbert-Bennett at UNC has written a lot about this crowdsourcing, and I think it's a great way to get more observations. Now, they may not be counting toward Leapfrog, but they're going to count for you, and they're going to matter to you, and they have the added benefit of increasing awareness and getting more people involved, and you can figure out who are the highest submitters, and then you can train them to be real observers. So there's a lot of opportunities to figure out who's on your team and who the positive deviance is. So I would definitely say crowdsourcing is a good opportunity. Second, train other clinicians. It doesn't always have to be an IP or a nurse manager. We use secretaries. So even though we have this automated monitoring system, we still have to do observations because we got to figure out why people are missing. Like, I know that they're missing hand hygiene, but how do I know what to work on? I need somebody's eyes out there seeing what's actually happening. I need to know that people are dumping half the PURELL into the tray. Like, don't get me started on this. I mean, like, we put up these signs that show, like, this is the dose. You wouldn't underdose your patients. Don't underdose your hand hygiene. Okay, anyway. And they're like, but it takes so long. And I'm like, yeah, that's the point. Okay, social workers. Social workers are out on the units trying to get patients moved into, they're often waiting at the bedside on the phone, waiting for places to call back. They're sitting at those stations outside the patient's rooms trying to get things organized. They're great people to do some hand hygiene observations while they're waiting on hold. Pharmacists, people that are doing drug approvals or getting those prior authorizations. Anybody that has downtime or waiting time. PT, OT, they're all over the hospital. And actually, they've been some of our best allies. Hi over there. I haven't looked at you enough. They're some of our best allies in hand hygiene because they really do a good job and they care about it, and they have some really good ideas about how to do things, and I've found them to be really, really useful. EVS workers, they are some of the hardest people to get on board because they're so confused about when to do their hand hygiene, when not, but we have a lot of times when EVS workers have to be supervised by their supervisor because they're doing some sort of terminal clean for a patient with Candida auris or whatnot. And sometimes we ask them to help us by doing some hand hygiene observations and letting us know what's going on in the rooms nearby. Those are pulling people into infection control, making use of your team. Involving patients and families, there's a great article by Cheng. I find this one to be a little bit challenging because I don't love the idea of asking patients to have to be accountable for the hand hygiene that happens, but I do think it's fair to ask them to rate it. And I think that families in pediatrics, the evidence shows that families in pediatrics are really good at this. So if you are in a peds hospital, that's a great thing to do. Unconventional observers. What about your leadership team? Why aren't they helping with observations? They might notice something that you notice every day, that people aren't washing their hands, and they might begin to care a little bit. What about students? I've got medical students. You might have nursing students or radiology tech students. They can be really, really helpful because they often have downtime in between the work that they're doing when they have clinical opportunities. What about patient liaisons? The people that sit on those committees that help to determine what your heart and vascular team is going to focus on or whatnot. Those patient liaisons, they might be willing to come in. The volunteer staff, they may be willing to volunteer to help with some of this stuff. Work with your volunteer office. And then there's this really cool article about considering a robot that can do it. I mean, now this isn't like the Moxie robot that we have, who's adorable. And if you smile at the Moxie robot, she'll give you heart eyes. Have you ever noticed that? Do you guys have that? That's my favorite thing, getting a robot to give me heart eyes. So considering a robot is an option. And there are some really cool new AI tools coming out that are able to understand. I mean, we're doing this really cool project about AI and machine learning, trying to figure out if the room got, all the surfaces got cleaned properly, and it's really neat. We'll be talking about it in probably 5 more years. I'm real excited about it. But the bottom line is that that sort of thing could also tell us about other opportunities in the room without actually videoing anybody, right? And so it could tell us about whether or not people are opening up sterile supplies and they should have probably washed their hands before they used them, that sort of things. And so I think we're moving in a direction where we're going to get more accountability, more granular data, more information, and that can have us tailor our resources to what we really need to work on. Frontline ownership, culture change is driven by people who are in the culture. I cannot tell you enough. You cannot have a one-size-fits-all solution. Just work with the people on the team, even if it means that some units are going to get 200 observations this month and the other units are going to get 50. This unit that's getting more observations, is getting more feedback, that's getting more stuff, you're not just observing for whether or not they wash their hands. You're observing for why didn't they? Because they had a bunch of stuff in their arms and they didn't have a place to set it down and they didn't know that they should wash where they were supposed to set it and then wash their hands. Or I don't have dispensers inside the room in this unit because it's just an obs unit and yet they still have no place to set them down. We had this problem, fixed it by just putting some more dispensers in the rooms because they needed a place to set things down. Positive deviance, finding out, well, that person always washes their hands. How do they figure it out? How can I ask them, what do you do when you have too much stuff in your hands? And then have them, then you can go back to the nurse manager and say, hey, this is what your people who do it right are telling me. Can you talk about that with people? Sometimes hand hygiene isn't about hand hygiene. It's about batching tasks and not going in rooms all the frickin' time for nothing. If you batch your tasks and you say, I'm gonna get all the things that this patient needs before I go in the room, in our hospital where the rooms are really, really big, the number of entries, and they're further apart, the number of entries per patient day are lower than in the hospital where the rooms are really close together and they're on both sides of the hallway. And so the nurse has like 2 patients that are really or 5 patients that are really close together. And they're just in and out of those rooms all the time. They're like, Mr. Jones, what do you need? Oh, you need a pillow? Okay, I'll go get that. And then they go in the room and Mr. Jones is like, I want some water. And they're like, okay, I'll go get that. And they don't realize that this is not one episode of care, because in nursing school, they were taught we clean our hands, we do our patient care, then we clean our hands at the end. And they're just doing their care. But when you're in a bigger hospital and things are further apart, then it's like, hold on, Mr. Jones, what are all the things you need? I'm gonna go get them all and then bring them back. And that is something I never thought of. But you won't know that unless you go and ask people. Focus on coaching, focus on sustainable progress, focus on little improvements. You don't need to do a lot. This is an ICU, this is old data, but it's really, really instructive here. Sometimes it's like you just keep throwing stuff at the wall and you figure out later what worked and what didn't. Sometimes just doing a bunch of stuff is what it takes to get people aware. And it doesn't matter if you think it's gonna be a good intervention or not. Just let them do it. Like putting a hat on the hand hygiene champion. I thought this was the worst idea. Who wants to wear a hat? And like, is that hat gonna get contaminated? Like, you can imagine. Like, is that washable? Can you clean it? What is it? Are you gonna share it between people? What about lice? Like, okay, right? There's a lot of things there. But like, it really worked for a little bit. Then they stopped using the hat. Anyway, don't judge. Whatever they wanna do might work. Let them try it. So what does work? We've been doing this for a long time. I will tell you, just-in-time coaching is the most important thing. You can also call it reminding. It's sort of peer support. It is, we all need help to remember not to do, it's like the friend who calls and says, hey, let's go to the gym together. I know you don't want to go, but we said we were going to go, so we're going to go. It's that kind of thing, right? And then involving unit secretaries. We forget about the unit secretaries all the time. They are really useful. You can ask them what they might be able to do to help you. They often see things that you don't know about, and they often have insight about why things work or don't work on a unit. Try and change the culture. And that means just letting them do whatever they want sometimes. And who cares? If you're not running it, you don't have to control it. You could just be like, great, try it. I'll come back in a week and ask how it went, right? You don't have to be there running everything. I know it's hard to let go of control. I get it. I am the same. But you can do it. And if you just let them do it, they might figure it out. When you have observations, it's not about just putting the number down. It's about getting information about what's happening on the unit, how people think about hand hygiene, where the problems are, because they're shared. The people on the unit are telling each other, oh no, that's okay, you don't have to do it that way. And practices can be widely different on one unit compared to another unit. And so it's really important that you understand what's happening on a unit level, or whatever your team level is. Visual reminders, don't forget to change the signs and put stuff up. I mean, it's crazy, but it totally works. But don't change your isolation signs. We tried that in a study once, it's terrible. Nobody knows what to do. The isolation signs, they're just looking at that as like a visual, it's like a stop sign. They know what they're supposed to do when they see a stop sign. They know what they're supposed to do when they see the green contact precaution sign. Don't change those. But the hand hygiene signs, you need them to pay attention to, so you want them to be. I once had somebody get real mad at me because they wanted, in our new hospital, they wanted all the signs to match. And I was like, so no one sees them? That's a terrible idea. Okay, so no, I got that. It took a lot of, it had to have a lot of meetings about how we should not have standardized signs for hand hygiene. It's great that Peggy wants to put pictures of her dog in a sheriff's costume to make people wash their hands. I don't care. Okay, we also do hand hygiene calls, and we've done them off and on. They're really, really good. So what it is just a cadence. It's a way of expanding your work without you having to be there. It's a huddle on the Zoom now. We used to be on the phone with like 5 to 9 units in a team, and they talk about what their hand hygiene compliance was on their monitoring last week, which means that they had to do the monitoring because there's peer pressure to show up with some data. And then you ask them what they did in order to improve hand hygiene last week, or what the problem was. Everybody talks about it. It's like really fast, but what it does is it ensures that there's consistent action toward hand hygiene on the people that are accountable for those units. And it's in a like sort of like peer coaching kind of way. And you can check about 27 boxes for the IPs without having to leave your office. And so I think you should be out on the floor. I mean, I think everybody should be out on the floors, but sometimes you just need to get stuff done. And this is a really great way to get things done. So I strongly recommend doing these, and we can talk more about it anytime, and you'll get these slides. Never, ever let a good outbreak go to waste. You know what I'm talking about. So this is a Candida auris outbreak in our cardiovascular ICU that we just finished. This unit was the most difficult unit to get. All the ICUs have great hand hygiene, but this one, I just couldn't get it. You know, like ever since 10 years ago, they combined the surgical cardiac ICU and the medical cardiac ICU into one unit. It's been like the Hatfields and the McCoys in there. And like, I can't get that, like the nurse manager's like, I can't deal with these people. Like, we just are never gonna make it. And she was the biggest apologist for the hand hygiene rates. And then we had an outbreak, a Candida auris outbreak, and we spent more time on the unit. I was personally going in and doing rounds at like 10 o'clock at night. You know how it is, right? You're just like, well, I guess we're gonna have to do this now. And the nurse managers really cared because they weren't super into hand hygiene, but they knew that this was important. And so they showed up, we showed up. We didn't have any extra people to do like a really, really like intensive, like all the time thing. But I'll tell you what happened. The nurses started to care. We put everybody on universal contact precautions, which is real popular, by the way, if you've ever done that. But everybody did it, and we yelled at them for not tying their gown in 2 places, and we were real strict, and we were really, really pushing for everything, and no, you can't sanitize your gloves. And that I'm not including in this talk, but that is another topic. I'm sure somebody will talk about this. Maybe you can, it turns out, but that's not our policy. Okay, but anyway. So we had everybody on this unit, and it turns out that they can do really great hand hygiene when they need to do it. And the nurse manager of this unit looked at me after the outbreak, and she said, I did not believe that we could have hand hygiene this good. I just assumed that everybody was trying as hard as they could, and because I know these nurses and I love them and they're doing an amazing job, and I didn't think that we could budge. I thought there was so much noise in the data that we would never be able to see improved hand hygiene. She said, I was wrong. And now she comes to the hand hygiene meetings and she's like, you know what? If we can do 60, 70%, you guys can do 60, 70%. There's no excuse for this. We're just missing opportunities, and we just need to buckle down and find them and change them. And she has a completely different rhetoric. And that I have won over the biggest stick in the mud I had. And I am so happy about it. But that was a hard one, right? And so now we use that to help move things forward in other places too. So never, ever I mean, they're trailing off a little bit, but they're still significantly better than they used to be. And that's the June data. This is really just a few days by the time when I downloaded this. So I think they're really running in the 60 to 70% range. So I think that this unit is doing amazing now. And I would love to have every unit have the after effects of an outbreak without having the outbreak, and someday I'll figure out how to do that. And then I'll come tell you all about it, but I haven't figured it out yet. Okay, so first steps, first things to do. Always be checking. Check on every level of the organization. If you want managers to be talking about it, you gotta check in with managers. You can't just do observations of frontline people, whether or not they're cleaning hands. You gotta check in, what are you actually doing about hand hygiene on your unit? If you want doctors to be talking about hand hygiene on rounds, you've got to ask them, when was the last time you talked about hand hygiene on rounds? You can't just send them an email and be like, now I want you to do this, and then assume that they're going to do it, because that's not how behavior works. So don't just check to see if people are washing their hands when they're going in and out of rooms. Check to make sure the other layers that you've put into place that are supposed to support that practice are actually happening. Audit for opportunity, not just opportunities, but like, what are the unique hand hygiene challenges in this particular unit? What is the culture issue? Is there some sort of weird idea that like maybe when you're looking, you can also look at things like cleaning shared equipment. Do people believe that those wipes are gonna cause cancer if they use them to clean off their stethoscope? People believe that. It's an urban myth. I don't understand it. I mean, as long as you don't eat them, you should be fine. Education is not an intervention, it is a start. You can educate people, awareness is, like bringing up the same thing over and over again, that can be an intervention, but just explaining to people, the problem is not that they don't know how to do, like in some cases, they don't know how to do hand hygiene. It's just a level, it's just putting everybody on the same level, but then you have to intervene from there. It's the beginning, it is not an actual intervention. Expand your time frame. Don't just look Monday through Friday between 9 and 5. See if you can find out if there's an EVS manager who can help you, or a social worker on the weekends, or somebody from your team can like have half a day off on Wednesdays, but then come in on Saturday mornings or Saturday evenings, or even flex to lots of different things. Getting the night shift isn't impossible. They start at 7 in my hospital. That's like letting somebody start at 10 a.m. and working until 8 instead of having them start at 8, right? Or I guess maybe more like 11 or noon. But you understand what I'm saying. Like, you can do this if you just think outside the box. Leverage technology for monitoring. If you can get automated monitoring or online, or use direct observation tools that are online, scheduled email blasts with the stuff, anything you can do to make the job a little easier. But automated monitoring is not just a plug and play and now I don't have to worry about hand hygiene anymore. It's just a tool for getting the observations done, and so you have to do different work. And be the tortoise. A unit that goes from 0 to 100 in like 5 days is not gonna be able to stay there. That outbreak unit that went up to 90, I mean, they're down to like 60 now, but that's a lot better than where they were before. And so we have to make some improvements, and they have to be small and iterative. Just like somebody who loses way too much weight too quickly, that's not gonna stay off. Somebody who goes, I mean, cold turkey, I guess, works for some people for cigarette smoking, but it's often when they've really thought about it and they've tried quitting multiple times before. So you really have to think about being slow, celebrate 1%, 2%. I showed you how many hand hygiene opportunities that we have. 1% is huge. That's a huge improvement. So don't give up. But if you're only doing 50 observations, then maybe 1%, I don't know what that means. But the point is, try and get what you can get. Budget. It's not in the budget. We just don't have the money for that, if I hear that one more time. It's been really tough. So we're building this new cancer hospital. We don't have there's been a lot of pressure on finance and healthcare. Patients are sicker than they were before the pandemic. We all know that. No matter how you feel about what we did during the pandemic, they're sicker now than they were before, and there are more of them. And there are fewer hospitals and fewer beds. And so we need to get our patients through the system and out of the hospital faster than ever, and there's a lot of focus going to that. And there's a lot of focus going to getting more done with less money. And that means, in my experience, that plus the backlash of having to do so much infection control during the pandemic has created an environment where people just are like, you know, you guys are gonna be on the back burner for a little bit. I feel that. I feel like people are like, they don't say it out loud in these words, but they're like, we did everything you wanted in 2020. Give us the chance to do some other stuff now. And I get it. I understand. I know they want to do their things. I get that. But there's no time when it's okay to sacrifice patient safety. And that makes it hard for me to sleep sometimes, because I feel like sometimes that's what's happening. But this is not the first time this has happened to me. I have been doing this job for a long time, and we've had other downturns in the financial situation in my particular hospital. And we've had other times where we've been particularly understaffed, and I learned from those times that this is an opportunity to set yourself up for when the money starts flowing again, because it will. There will be an outbreak that someone will say, we used to not do Candida auris screening in-house, and we had to send it out to Mayo because the lab couldn't possibly do it, and they didn't have the machines, and they didn't have the staff, and it was so expensive to send out to Mayo, so we couldn't do any screening, any admit screening, and we just needed to figure it out some other way. I don't know what that means. And then we had this outbreak, and you wanna know what? We do Candida auris screening in-house, and now we have a Candida auris screening program because we were ready. We knew what we wanted to do. We knew exactly how we wanted to do it. We knew how we were going to implement it. And so when they said, we can afford this now because we can't afford another outbreak like that, I said, great, here's what we're going to do. And we had everything set and ready to go in advance. That's what you need to be. You need to be ready to jump on any opportunity. And what that means is start talking about your new hand hygiene monitoring system as though it's real. You just tell people, well, when we get our monitoring system, when we get that automated system, then we're going to be able to do this so much more easily. Oh my God, getting these 200 observations a unit is really hard for us. But once we get that badge-based system, it's going to be so much easier. And boy, that's going to save a lot of time for everybody. Think about all these people I've got doing observations now. We'll be saving that time. They'll be able to do other things for hand hygiene, but we're going to be so much better when we can have more granular data. Boy, it's gonna be so great. I met these people. I know this company. I've looked at this one. This is the one I wanna trial. The minute they say, you know, you've been talking about that badge-based system, and you mentioned something about a trial, you say, great, this is the unit. I've got them all lined up. They already are ready to do it. The manager's on board. This is the company. I know their name. This is how much it's gonna cost. And let me connect you up with them so that we can get it started right away. Have your ducks in a row, because that moment when they realize, I care about hand hygiene, you need to be like, here's what you need to do on a platter. So get it ready. Get the word out about your idea. Get the unit socialized to the idea of doing a trial. Talk to people about, well, once we get a new hand hygiene observer, when we get this program with the volunteer office off the ground, then we're going to be able to do our hand hygiene observations, and the IPs are going to get to focus on doing actual improvements for hand hygiene. That's what you've got to have. Do the math ahead of time, make a plan, be positive, have it all ready to go. Just like that vacation that you really, really want to go on to Machu Picchu that you've planned out like 7 times, and you're ready to go. As soon as you are ready to go on that vacation, you're like, I know exactly what I'm going to do. Right? I have that vacation planned out. I want to go there. My son does not want to go there. Okay. So the point is, you know what I'm talking about. So get your stuff done, and then when you are, Scrooge McDuck jumping into the money pit for hand hygiene, that does not exist. You know what you're going to spend every penny on. That's the most important thing. Last thing I want to talk about before I let you ask me any questions that you want to ask, and this is, I'm going to talk about the taboo stuff that we're not supposed to talk about. It's really hard right now. I work at a hospital, and I'm an infectious disease doc, and we've lost $15–20 million worth of funding for huge projects that are things like how to get HIV patients tested, like people that don't know that they have HIV yet, tested, HIV elimination programs, how to get people to their appointments, how to get PrEP into people that are at really high risk of HIV, all canceled because of ideology of somebody that's not me. And some of those projects are so far down the road that we've just, thrown out billions of dollars worth of data because we didn't do the last 2 months. And it's really discouraging. And then having all of the ACIP committee, fired so that we can put a bunch of anti-vaxxers. The political situation is really hard, and it robs us of our ability. It makes us worry about other stuff. It takes away from us, and it takes away from everybody working in your hospital too. Everybody's really troubled by this when they work in healthcare and they see things like Medicaid cuts coming down the pike. And that, we have to account for that. And we have to understand and hold space for the idea that everybody's really struggling. No matter what their ideology is, everything's changing, and change is really hard. All those things that I said about behavior change and like depression and having denial and being angry about it and bargaining on things, that's happening for every single one of us about everything right now. And that means that getting anything done is happening in a different kind of vacuum. But it's really important to remember that we are in this. We all came here for the same reason, no matter what our ideology is, no matter how you feel about any of this, no matter what's happening outside your hospital. When you sit down at your desk or when you walk into your office or your hospital, you came here to take care of that patient, to make that patient's care safer today, better. And that you can keep doing. Even if some of your grand plans aren't as good or aren't going to be accepted, or maybe some other things aren't happening, maybe we have to just do smaller things for a little bit. We have to do smaller things for a little bit because it's worth it. It's worth it. Our work is so important. And no matter how many people tell you, I'm sick of infection control because we did so much of it during the pandemic, or it doesn't feel like anybody really cares about what we're doing in infection control anymore, you know that it matters. That 1% improvement in hand hygiene, the one person that you can turn around their idea about hand hygiene, the one place where you can get people to really focus on it, it matters. It matters to somebody's mom, it matters to somebody's kid, it matters to somebody who doesn't go home with Candida auris, and you know that. So no matter what's happening outside, just remember why you're doing it and keep taking steps forward, even if those steps aren't as big or as grand or as good as what you wanted to take. Just keep taking steps forward. That's the best advice that I have for hand hygiene, for living in this difficult time, for putting up with really bad finance situations, being terribly short-staffed, and any other thing that you are facing. Any outbreak situation where you're like, oh my God, how did this happen? All you need to do is just keep taking one step forward. And I hope that wasn't too sad of a note to end this on, but thank you so much for listening to me talk for however long this thing has been blinking. I don't even know how long it was at the beginning. But I hit it right on the nose, right 45 minutes, look at that. Okay. I will answer any question you have. I don't know that I'll have a good answer, but I'll tell you if I think it's bad. And I'm happy to answer your hard questions, including the ones that you don't think it's okay to ask in a public setting. I'm really not afraid of anything except a norovirus outbreak. Oh, I don't want that.
Yeah. What we'll do is we have runners with mics, and if our runners would kind of maybe speak into the mic wherever you're at, we have a hard time seeing, wave your hands. Even with you wave your hands, it's hard with the light. So wave your hands if you need to speak, and then wait to ask your question until you have the mic in front of you so everyone can hear the question. So we will get started. Okay, got a question right there in the middle.
Thanks, Dr. Landon. Asif from California. One of the things that you mentioned, and I want to dig a little deeper into it, some units perform better than the others. Has there been any data that it is dependent on the leaders who influence much more, such as physician leaders? Intensivists may have a better hand hygiene versus hospitalists, probably. Do we separate that to figure out who we need to focus on?
So if I had a badge-based system where I could tell you who was doing the hand hygiene and who wasn't, I could answer your question, and I'd really like to be able to do that. But the answer that I have is that there are some things about ICUs that are just different settings. My observations are that because the nurses have fewer patients, they do less entries and exits. There are more entries and exits per patient per day, but they are they're doing more in-room hand hygiene, to be honest with you, because they're doing more aseptic tasks and they're doing more contact with bodily fluids, which are actually people are pretty compliant with those in our experience doing like 5 moments monitoring. People are really good at that. And so we see a lot of that, and there's still problems with the entry-exit hand hygiene, but in an aggregate monitoring system, it just looks like their compliance is much better because I'm only counting the denominator is entry-exit. So I think I think that is a reason why I see the ICUs do better. Now, I do have data that shows, and I think we've published on this, but maybe I've just put it in presentations, where we have a closed ICU, where there's one attending that is responsible for the entire patient population, or 2 attendings, they tend to do better than open ICUs, where one attending has 1 patient, and which is more like a floor setting, where there's lots of different physicians for lots of different patients. And I think that's the team effect, right? So different teams do different amounts of hand hygiene in my experience. Now, this is really hard to tease out because of a lot of it's like sort of looking at the data and then also looking at observations. But I will tell you that some of the teams are great. If the attending cares a lot, then they will make sure that their team does a really good job, whether they're in the ICU or whether they're on the floor. But if the attending doesn't really care or isn't really focused on it, then they might not do it. I lecture the medical students every year, and because the other thing we've noticed is that people are lemmings, and if one person in a group washes their hands, everyone else will do it too. And so we tell the medical students to be the head lemming when it comes to hand hygiene and contact precautions, and we ask them to just be the first person to use be the first person in the room, first person to use the hand sanitizer, and it works. On our observations, we've done we've had some like fellows do some observations, and I think we've had some posters about it, but probably not a big paper because there's not a lot to say about it. Maybe we should write it up. But where they show that if anybody on the team washes their hands, then everybody else will. And so I don't know if our medical student intervention works, but it helps. We know that if one person hands out gowns to everybody else, then everybody will put them on. They're not opposed to wearing the gown until if somebody hands it to them. But if they have to walk themselves to the drawer to get the gown, it's like a whole nother problem. So these are like little things, little tweaky things. The reason that some units do better is because their nurse manager cares more and does a good job at behavior change. That's the answer that I have for you. If the nurse manager understands that this is a behavior change problem and they have some experience or understanding of what to do and they treat it like that, then the unit does better. If the manager feels like they can't do it, then the unit's terrible. It's all about the nurse manager's confidence that they can have better compliance. The nurse managers that do not think that they can have better compliance do not have better. It's a total self-fulfilling prophecy. I will say that is my experience overall. But I don't really have a good way of measuring someone's confidence so that I can write that down in a paper. If somebody knows of a scale of confidence, there must be somewhere. But yeah, that's what we have. Some nurse leaders are better than others. And ours are, because it's an aggregate system, it's very focused on the unit as a team, and it's very nursing-led and nursing-driven, because the physicians are all over the place, but the nurses are on their unit. So that's the difference between a badge-based system, or if we were doing more structured observations, direct observations, we'd be able to have different information, but one of the limitations of my system is that it has to be unit-based, and that makes it very nursing-based. I hope that answers a little bit of it.
Dr. Landon, we have one over here.
Oh, hey.
Hi, I have a lot of units that report their hand hygiene observations, and most of them report 100%.
Oh yeah, sure they do.
I do have several units that will report honestly. I've had 35%, and I love that, and I celebrate that, and I tell them thank you for being honest. But do you have any other ideas?
I do. So you can do what I did, which is not a good idea. You probably shouldn't do this because it was a little provocative at the time, but this is how we got our hand hygiene system. I refused to report the hand hygiene data, and I said it was a lie. And I said this at a large medical executive committee meeting, and the chief nursing officer wanted to kill me. But I got a hand hygiene system. Okay, so you could try that. That's one option. But another option is to require people to give you not just their hand hygiene observation data, like the numbers, but what the opportunities were that they found. Like, and requiring them to give you the, so that's what we require now. We require, when we do, because we still do PPE observations, we require people to tell us their PPE compliance and their the opportunities, like what was missing that kept them from doing it. And so you're gonna have to say, I'm sorry, if you've got 100%, you're gonna have to just keep watching until you can find somebody that didn't do it. These are all high achievers. Everybody that we usually ask to do hand hygiene observation is a high achiever that wants to get 100% on every test. I strongly recommend finding the not high achievers, and I don't want to call them low achievers, the less stringent high achievers, and ask them to do your hand hygiene observation where they don't care. Like, why would the social worker care what the hand hygiene is on 4 West, you know? Like, it's not her problem. So I think that's another opportunity. Yeah. Oh, there's a bright light. I can't even see this person.
That was going to be my question. I collect, our team collects hand hygiene compliance, and then I've started sharing the data that we get versus what the unit gets.
Oh, yeah.
And we're like 67, maybe 75, and then the units are reporting 97 at worst to 100%. And then we have a couple units that are very brutally honest, and I love those units for that, but we do the 5 moments of hand hygiene, and it's still not working. So I might go with your first suggestion. And
I think this is just a lie. You know, maybe don't say lie. That's what makes people mad. You could just say, look, I don't think this is accurate. Like, we're not getting accurate numbers. And so you could try asking, like, this is when I would probably resort to saying to leadership, can you come do hand hygiene observations with me? Would you be willing to put some into this little app if I can give them to you? Like, could you go do some and see what you see? Because they don't expect that that's what the leader is doing when they're on the unit. And some of the frontline staff probably doesn't even know who your leaders are because they've never been to your units, most likely. And so that may be a good way to get them out looking. And I think the more you can get people to the bedside, like especially leadership, onto the units to the bedside to see what's happening, like, it's good. Something to think about. Okay, there must be somebody else with a question.
Dr. Landon, we have one over here.
Oh, hi. This is the side of the room I've been ignoring too much. I tried. Sorry.
Hi, thank you for your presentation. So we have digital solution for hand hygiene that count same opportunities going in and out of the rooms. And I wonder if you what your experience is with effective hand hygiene practice. So yes, they do get the hand sanitizer, the hand rub, but they're not doing effective hand hygiene. They might get it on one hand, walking in, walking out. They might just...
Oh, my favorite is this one. You guys see that? You know what I'm talking about. They put their hand under the dispenser and then they go, and like they flick off all the stuff. And then they put like the like tenth of what they actually got on there actually.
Yeah,
you know.
So that's a big challenge that been trying to crack our entire company, the IPs, everybody else is happy that they can count opportunity and they see great numbers with the compliance, but on ground, when you're really looking at the practice, when you're really doing the observation, you're like, why did they do that? And sometimes this digital solution, yes, they give great numbers, but the IP still have to do the work. The literal observations still have to happen, and that's really like a big challenge because it's not about getting great numbers, it's about our resident safety.
That's 100% correct. Getting an automated monitoring system is just frees you up from getting that baseline number. It doesn't stop anything else you have to do for hand hygiene. And just because you have a number doesn't mean that you have what you want. But it does mean that all of a sudden you're now focused on improving the quality of the hand hygiene, not just getting people to do it. And I think that's where we want to be, right? So yeah, so I definitely hear about this. Mostly I hear about it from EVS because they're like, the floor under the dispensers is terrible. It's so messy. Like, why is it dripping everywhere? I think the dispensers are leaking. I'm like, they're not leaking. I know what's happening. So then that's the unit where I go and we send people to do observations of what people are actually putting in their hands, and we start putting signs and like screensavers on the monitors. Like you can, sometimes hospital, that's really helpful, by the way, if you do not have, like all of those like devices, the mobile devices that you all have screensavers on them, and if you can figure out who makes those screensavers and if they can let you put signs on there, like your own slide there, that's really good. And so we have some that say this is the right dose. Like this is what I was talking about with the dosing. This is how much you need to apply to your hands in order for that hand hygiene you just did to be effective. So why did you bother if you're not going to do it? And people actually respond to that. They just didn't think that they needed so much, is what I hear a lot. They're like, I didn't know I needed to use all of that. I just thought it was way too much. I thought the thing was like trying to sell us more stuff. And I'm like, no, I calibrated them to give you that much on purpose. Like, what are you... Yeah, so, but that's like they didn't realize that, and so they needed to hear that. That's where an educational intervention is kind of useful, but then you have to follow it up with like, hey, get that belongs on your hands. Like, I get that satisfies the system, the electronic system, but you didn't do what you need to do for the patient. And that argument is good. People like that argument. People are like, you're right, I didn't, I should do better. Yeah, and I think that helps. So but I also really like that we're moving into the domain of talking about how effective the hand hygiene is, not just how often people are doing it. Okay, I'm sorry. Yes.
Hi. How do you deal with doctors when you do rounding, like we started doing rounding on the units, and I have social workers and occupational therapists,
so good.
all them watching now, but the doctors are like, I did not touch the door going in.
Oh,
I didn't touch
anything.
The patient. I did not. I just stood there and talked and then came out.
Yeah.
How do you address that?
Couple ways. There are a lot of studies. If you do a quick search on PubMed for, I don't think you can just search for I didn't touch anything, but you can, there's like a great study from the pandemic of infectious disease doctors during a conference who are like, I don't touch my face, and then like they videoed them, they're all touching their face all over the place. And there's all kinds of studies showing that people touch stuff all the time. They touch the curtain, they touch the